Hi to everybody who's just joined. We are going to get started in just a minute, but as we wait for folks to hop on the call, you can introduce yourself in the chat. We'd love to hear your name, where you're from, and what organization you're with. I can see some intros rolling in right now. It's great to see the representation we have so far. So please keep that coming, and we'll get started in just a minute. Thanks. I think I'm going to kick us off. I'm sure people will continue to roll in, but for the sake of time, we'll just get going. Good morning, good afternoon, good evening, everyone. Thanks so much for joining us for this webinar presented by Adolescent 360, Breaking Barriers, Engaging Household Level Key Influencers to Transform Social Norms for Adolescent Contraceptive Use. My name is Mary Phillips, and I am a technical advisor with Adolescents 360 at PSI. I am based in beautiful Syracuse, New York in the US, and I will be your moderator today. Next slide, please, Angelica. So just very quick Zoom introductions. I'm sure most of you are quite familiar with Zoom as a webinar platform, but just to note that we have two options for chat. One, many of you have already found. Please feel free to introduce yourself, leave comments. The second is a Q&A button. So please, as the webinar goes on, if you have questions, do try to put them in the Q&A function. It just helps us on the back end to manage all the questions and make sure that they get answered. So again, there's the chat and the Q&A. Thanks. Next slide, please. Today's program, we are in the midst of the welcome and background, and then we have three great presentations from each of our representative countries, Kenya, Nigeria, and Ethiopia, on their strategies for key influencer engagement. And then I'm really delighted that we have the chance to have a short panel discussion with some folks who are directly involved in implementing these strategies in these countries. So we'll be able to hear from them. And then we're hoping to have time for question and answer and some discussion. Next slide, please. Great. So before we begin, I just want to give a brief primer on Adolescents 360 so that if you're not familiar with us, you can hear what we're about. We are reimagining how girls understand, value, and choose contraception across Nigeria, Kenya, and Ethiopia. Initially, this project was funded in 2016 by the Children's Investment Fund Foundation and the Gates Foundation, and we are now in a second 5-year investment phase that actually wraps up this year in 2025. And to date, we have supported over 1 million adolescent girls aged 15 to 19 to voluntarily take up a modern method of contraception. Our approach really focuses on positioning contraception as a tool that can help girls pursue their aspirations. And we expand contraceptive method choices and strengthen health systems to be more responsive to the unique needs of adolescents. A360 is led by Population Services International, the Society for Family Health in Nigeria, and Population Services Kenya. While our focus is on supporting and empowering girls to live the lives that they want, it's very clear to all of us working on this that the girls are hugely influenced by the people around them. So their husbands, their partners, their mothers, their fathers, their mothers-in-laws, and religious leaders. And that those figures can be a positive or limiting force in their lives. So if we want to expand access to contraception, we have to work with these influencers. And today we'll be talking about the ways that we have engaged those influencers to be champions for girls' contraceptive use. Next slide, please. So I'm very pleased to introduce our speakers today. First up, we'll have Berkisu, who is a strategic behavior change communication specialist based in Nigeria with SFH. Then I'll hand it off to Purity, who is the A360 Narok County Coordinator at PS Kenya. And then finally, we will wrap up with Messen Getachew, who is the Adolescent Youth Sexual Reproductive Health Manager based in the Afar region of Ethiopia. So with that, I will hand it off to Berkisu. Thanks so much. Oh, Berkisu, you just have to unmute.
Hi, everyone. Hi, Please confirm you can hear me. I'm excited to be here to share husband engagement in Nigeria approach with everyone here. The key influencers, who are our key influencers? Our key influencers are the husbands of the adolescent girls. We have the community and the religious leaders. So the key influencers engagement in the North was developed actually to improve the enabling environment for contraceptives uptake for married adolescent girls through direct outreaches to the husband. The approach was built on existing strength of the male interpersonal communication agent who effectively engaged the husbands at the community level through small group discussions and one-on-one conversation. So the religious leaders are also integrated into this discussion to moderate the community members or to mediate between the community members and the IPCA who comes into the community to share these to hold the sessions at the community level. The MIPCA provides, that's the male interpersonal communication agent, provides technical content while the religious leader convenes the community members. When needed, he also uses religious texts to justify contraception for child spacing at the community level. So based on that context at every point in time or at every community in time. So the sessions are held in spaces where men naturally gather within the community, and the religious leader using this or leveraging on this existing community dynamics ensures that the religious leaders at that point becomes the champion for child spacing. The community leader also becomes a champion for child spacing at every of their community where the MIPCA engages in. Next slide. So taking us through the overview of our engagement. Now looking at our context, what's our context? The context covers early marriage. So early marriage remains a common practice in the northern Nigeria, where we have 60% of the girls being married before their 18th birthday. And then marriage shapes adolescent girls' option in the north. And then promoting child spacing. A360 collaborates with young people and government health system to address barrier affecting access and use of modern contraceptives amongst the adolescents aged 15 to 19. The A360 also created enabling environment for child spacing and ANC services in our 4 MMA implementation states. And the MMA stands for Matters and Matter Area, that is unmarried adolescent girls in the north. And our implementation states are Kaduna, Kano, Jigawa, and Nasarawa. Next slide, please. Our context is around girls' limited autonomy, why it matters. In the northern Nigeria, like I said earlier, men are most of the decision, men make the most decisions in the household and primarily influence young wives' action, including access to healthcare. Thus, the need to involve gatekeepers, including the husbands, in any effort to reach out to these young married adolescent girls. Many of the adolescents cannot on their own do not have decision power. So they depend on their husbands or the elders for permissions, even to seek health care. Next slide, please. So who are our target audience? I've earlier said that our target audience are married adolescent girls who are between the ages of 15 to 19. And 11% of these adolescent girls covers the population, the Nigerian population. And most of these girls have poor access to timely and appropriate health care, which put these girls at risk of complication during pregnancy and childbirth, which can lead to long-term morbidities and even mortalities. Next slide, please. How it works. How does our husband mobilization and engagement works for us? It begins with the MIPCA having a map, that's having a work plan, identifying location or communities where he will visit per day. And at entering of every community, he ensures that he meets with the community leader to introduce the program to the community leader, and encourages the community leader and the religious leaders in those communities to become champions of child spacing. And they also align or collaborate with him to mobilize men. And this mobilization takes place at the community level, like I said, in a gathering where it's either at the mosque or, it's either outside where men usually gather, maybe after mosque prayers, or during a sit-out for the men during their Majalisa sitting. So all of these men are introduced, during mobilization, the men are introduced to sessions on child spacing, role of men in child spacing and modern contraceptive use, and linking them to SRH through using a structured IPC flip chart. So this structured IPC flip chart, you can see a pictorial picture there. This picture is used to generate conversation, or this picture is used to generate conversation. The MIPCA uses this picture code also to generate conversation, inform the MIPCA, the husbands, what do you see in these pictures? That's also is part of what he uses to generate conversation. He also has a referral card. After introducing the men, and the men understand the importance of SRH, he gives referral cards or referrals to the husbands who have adolescent wives who are ready to access any of these services, either for ANC or for child spacing. And then when he gives these referral cards to refer the wives for the program, at a point, these wives attend this program either through LFH. Well, LFH is Life, Family, and Health, which helps to build the girl life skills and girl capital outcome of the girl. So it's either they're coming through these life, family, health classes, or they're working directly to access these services at the facility, depending on the interest or need of the girl. And then at the end of every month, the MIPCA follows up with the facility. Before then, he follows up with the male, with the husbands of this adolescent to ensure that these services these girls have obtained the services. And then he follows up to the facility to redeem the cards that have been the cards for services that have been obtained, and then he reports accordingly. Next slide, please. So some of the results recorded for key influencers engagement from 2020 to date are, at the community level, community engagement have strengthened the buy-in of 4,374 community leaders and religious leaders, and also 811,802 male partners through community dialogue. At the household level, survey, the key influencer survey the result from the key influencer survey that was obtained was shows positive shift in social norms, and perceived spousal support for contraception surged from 18% to 72%, and then 70.9% of intervention participants reported strong social approval. Then partner disclosure of contraceptive use improved to 98.8%. Then at the individual level, we have also documented and reported seen improvement uptake of modern contraceptive. Notable increase have been recorded in modern contraceptive use among the target population and the intervention areas, and this has resulted to 842,902 first-time users and 387,982 continuing users. Next slide, please. We have also documented lessons learned from our intervention. Some of the lessons learned are community-led and culturally aligned agreement, leveraging respected environment, community figures like the religious leaders and the community leaders have given in intervention credibility within the community, and the male involvement and collaboration. Sessions have helped the men to discuss issues with their wives, and also moving from just male-dominated decision-making makers to collaborative decision-making as a couple. Adaptive and flexible implementation. the flexibility in our design and openness in the community feedback were critical on the successes of our intervention. Stakeholders ownership and buy-in. Religious and community leaders not only hosted but also endorsed messages based on context of the location, making the approach feel local and very authentic. Next slide, please. Thank you very much for listening.
Thank you, Rikiso. So great to hear about the work at that huge scale with husbands in the very conservative area of northern Nigeria. And later on, we're actually going to hear from a male IPC agent. So stand by. Next, I'm going to hand it off to Purity in Kenya. So Purity, you're up.
Thank you, Mary, and welcome to our presentation. I'm going to take you through our version of key influencers as implemented in Kenya, dubbed Binti Shupavu Stories. Next slide. Next slide, please. Thank you. So just an overview of what we call the Binti Shupavu stories. We call them stories because in our communities, majority or most of the time, we give information through stories, through just dialogues and so on, the sittings, the under the tree sittings. So we took this approach to be able to reach the mothers, husbands, and the community leaders in our spaces. So for what we take to those spaces is actually correct information around contraception, and also just a recommendation or just calling out to the influencers to give the adolescents a supportive environment to be able to access in the contraceptive and also have a very supportive system around them. So we will see how we do that, and probably in the next slide, please. So in our context, we have the community structures, which are led by the community health promoters, as well as we have the women groups, just the existing forums that the key influencers usually go to just for their daily activities or their daily meetings. So in terms of onboarding, we do use these forums to be able to mobilize for awareness, just making sure we are setting up community forums and even using those that already exist. And we have the materials, as mentioned in the previous slide by the presenter that went before me, like the flyers, the job aids and all that we also use to, as we mobilize to spread awareness on the same. So the mobilization is very targeted towards the key influencers, and once they are here now, what do we do? What are some of the engagements that we have? So apart from the dialogues, because as I have said, our passing information in our traditional African society was mostly done through dialogue under the tree, and that is the same engagement we use, just making sure that we have the discussions right from the needs of the adolescents, what are their goals, what are their aspirations, and how can we as the mothers and the husbands and the leaders of the community be able to help them or be a bridge or a supportive environment for them to achieve those goals. And at the same time, pointing out what are the barriers, what are the existing barriers that are in control of those decision makers that can make it easier for the girls to achieve their goals. So that way we do a lot of myth debunking through audiovisual tools and also discussions, just showing them the effects or the effects of some of the traditional practices that are actually barriers to the adolescent girls. So in the same forums, we also get their perspectives, because as we go to the community also, we go with a perspective that, with a cognition that they also have their ways of life. And we do not go there to disrupt the way of life, rather just to be able to give alternatives to the harmful traditional practices, and also to give information and knowledge on how best they can be able to support. So at these forums, you are able to record some of the commitments that they give and listen to their stories, because they also have their perspectives that maybe out of lack of knowledge they still hold. And thus, that is where we get the baseline for the information that we give. So next slide, please. So what have we achieved through these engagements? Number one, I think a lot of acceptance has been seen through the engagements of the key influencers, just to be able to enable the adolescents to obtain consent, be it from the mother, be it from the husband, be it from an uncle, an aunt, or their guardian. There has been a lot of improvement in terms of the key influencers accepting for the adolescents to go and seek contraception of their choice, and also enabling them in the cognition that will enable them to achieve their goals, like going to school and finishing school maybe after a first pregnancy, thus delaying a second pregnancy and helping the girl to pursue their education comfortably. And also through our client exit interviews, it showed that there is a lot more conversations going on in the households among the married adolescents with their spouses. Some consultation is going into the decision making around contraception. So that is a plus for us, because traditionally the burden of sexual reproductive health is usually left to the lady or the adolescent or the woman. So there's a changing narrative there, where you find an adolescent talking about the consent, or even a discussion that went into her being able to access that contraception. We have also noted a lot of attitude change in terms of the long-acting methods. Due to their nature of the long-acting methods and the level of privacy that they do not have a lot of privacy. So most of the time, before, you would find the adolescents opting for the short-term method, especially the injection, because it has some level of privacy. But now the uptake of long-acting methods is going up. That means that there's a lot of reception around them taking up that contraception choice, and not be fearing that there will be consequences, or forced removals, or forced discontinuation. Also, we have the referral card system during the forums. We also provide what we call redeemed referral cards to the key influencers, that is especially their husbands, so that they are able to refer their wives to the facility using that card, and then they are able to redeem a service using the card. So the rates, the referral rates for the SRH have improved. So we see a lot of the adolescents now coming to the facility with referral cards, and that means there's something changing. There's a narrative changing around the acceptance of the same. So overall, contraception uptake for the women of reproductive age has increased. Based on the 2014 Kenya health survey, in the 2022 we have seen immense and very incredible improvements around the modern contraception prevalence, both for the adolescents and generally for the women women of reproductive age. So that means these efforts are going into to improve some of those. And as you can see, the numbers are changing from 41,000 in 2022, and now the key influencers have started accepting the sessions, accepting the forums, and even coming in. Next slide, please. So what have we learned in Kenya through our key influencer forums? We have learned that when we collaborate with culture, when we are able to show the key influencers that their culture is beautiful, it has good things, but also there's something that can change within that culture to make the life of an adolescent better, or the reproductive health of an adolescent better, then there is a lot of reception. And then it has to be continuous. We know as behavior change experts that change does not come overnight. So the continuous health education has to continue, and for them to be able to internalize the knowledge and even act on it and achieve some level of change. And also for sustainability purposes, we have leveraged a lot on the community structures in the government system, and that's why we have even the monthly community dialogues, the male involvement forums that are at the county level going on, and even integrating the messages around access of contraception for adolescents and engaging the key influencers. So yeah, next slide. Yeah, I think that is the end of our reflections from Kenya. Thank you very much for engaging. Asante.
Thank you so much, Purity. Really interesting to hear about the ways you're mixing sort of creative modern storytelling with traditional structures to sort of build this changing momentum around adolescent contraceptive use. And in the panel, we're actually going to hear from a government representative talking about how he's adapting this structure to fit the context of his local county. So that's coming up. But first, I'm going to hand it off to Mesfin from Ethiopia. So Mesfin, go ahead.
Okay, thank you, everyone. I am Mesfin from PSI. I'm working as adolescent and youth SRI program manager based in Afar region, Ethiopia. So I'm going to share our experience in family circle related achievements. So when you say family circle, it is an intervention developed through human-centered design and grounded in insights from rural and married adolescent girls as well as their influencers. So the program, family circle program, positioned contraceptive as a key asset for the success, the achievement of the life of married adolescent girls. Next slide, please. In Afar, teenage pregnancy as well as child marriage is highly prevalent when compared to other regions, and also the contraceptive prevalence rate or contraceptive acceptance rate in Afar is very low. So the main barriers for contraceptive acceptance are mainly the socio-cultural as well as gender-related norms, and also gaps in family planning related informations are the critical one. So our program mainly focused to achieve these, to address these critical barriers. Thus, through implementation of family circle, we addressed these two critical barriers, such as the social, cultural, and gender-related norms, and also we make family planning information accessible to those our target groups through creating awareness by helping them to understand the negative effects of teenage pregnancy as well as recurrent pregnancy, and also we provided SRH-related informations to understand the value of family planning to safeguard the mother as well as children life. When we implementing the family circle, maternal as well as pregnancy-related health complications are a hope to provoke the discussion Next slide, please. When you see the significance of the family circle program, it allows community-level key influential persons to engage and to take part to solve those family planning-related barriers at community level. And also it facilitates the intrapersonal as well as interpersonal communication, mainly to address the intrapersonal and interpersonal communication, which is mainly related with the knowledge gap as well as the influence of husbands, in-laws, and others. So having information empowers young couples to navigate the SRH service. It also helps us to reduce the gender-based barriers because husbands are part of a family circle, so they highly engaged in family circle program. So it reduces gender-based barriers. Also, we use the existing community structure, so it leverages existing community structure as a whole. It's culturally sound and also socially acceptable, and it is easy to scale up the existing program. Next slide, please. When we see our targets are those married adolescent girls aged from 15 to 19 years, and their husband as well, and also community leaders such as clan leaders, religious leaders, Kabbalah leaders are our audience, and also in-laws and peers of married adolescent girls are our target audience. Next slide, please. When we come to the key steps, initially we conducted a regional level launching workshop, which mainly aimed to onboard those regional level leadership team. Then we provided the training for health service providers as well as health extension workers who are found in our operational waradas. Those trained health extension workers also conducted Kabbalah level kickoff meeting by engaging those community level key influential persons like Kabbalah leaders, clan leaders, religious leaders, women development armies, Tibets and Latinas. After Kabbalah level kickoff meeting, family circle orientation also provided for women development armies as well as Latinas, which is mainly to make the program well understood by the participant, as well as to inform how they make identification of those married adolescent girls. Then identification and mapping of those adolescent girls was performed by key influential persons. After identification, they schedule a program and conduct a mobilization session by engaging the husband. After mobilization session, the key influential persons refer those married adolescent girls and their husbands to health post level for counseling sessions and also to have family planning service. After the service, there is also we apply a strong follow-up care to make sure the continuity of the service as well. Next slide, please. When we come to the results, through implementation of family circle, mainly through involvement of key influential persons, we created a positive social norm shift towards contraceptive acceptance. As a result, there is an increase in family planning acceptance rate in our operational waradas. Still, husband disengagements there is an increase in husband disengagement, which really supported to address gender-related influence. As a whole, there is an increased number of family planning adopters among girls aged from 15 to 19 years in family circle waradas. Next slide, please. As we can see from the graph, the vertical line indicates the starting period of the project. So there is an increased trend in both new adopters as well as repeated contraceptive acceptors among married adolescent girls aged from 15 to 90. So it shows there is an increase in trends of family planning acceptors. Next slide, please. When it came to the challenge, there were a lot of challenges when we start the program, but now after a kickoff meeting and recurrent dialogue with key influential persons, majority of the challenges are solved, and but still there are challenges from elders and clan leaders because they believe that it may decrease the number of clan members, so it may affect the influence of the clan, but still majority of key influential persons are well accepted the program. Still, they are supporting the program and part of the program implementation. When you go to the lessons we learned, engagement of those available key influential persons during community mobilization created a positive social norm shift toward this family planning, use of family planning by married adolescent girls, and also application of such a new and tested approach like family circle creates a new understanding, and also which is significantly contributes to creating demand for family planning in pastoralist areas. Next slide, please. Thank you.
Thanks so much, Vespen. Really interesting to hear about this program that is working in pastoralist areas of Ethiopia, which obviously is a region that has its own unique challenges. So that concludes our presentations. Next slide, please. We're now going to move to the panel. And I have seen these great questions come in the Q&A and a few in the chat. Please keep them coming. If we don't have time to answer them today, we'll do that we'll try to do that in our follow-up email, because they've been great and really interesting. So I'm thrilled to see the engagement. For our panel, so as I said, we're very lucky to have 3 individuals who are directly involved with implementing this work, so sort of frontline. We have Fatima, who is a health extension worker in Afar, who's going to talk to us a little bit about the experience of running the family circle. We have Tora Aitich, who is a government AYSRH coordinator, and he's going to talk to us a little bit about his experience with the Binti stories. And then finally, Ibrahim, who is a male interpersonal agent in Nigeria. The way this will work is I'm going to ask one question, and then our panelists will answer it, and each panelist will answer one question. And then we're going to open up the Q&A and invite our presenters back. And we'll try to answer as many as we can before time runs out. So we will start with Fatima. And Fatima is actually going to speak in Amharic. So Meston has kindly agreed to translate the question and her answer for us. So hi, Fatima. I see she's on the screen with Meston. So our question for Fatima is, can you tell us about a success story that you have had implementing the family circle, where you've seen this really work well and sort of change attitudes about contraception? Thanks.
እሺ አመሰግናለሁኝ። ስሜ ፋጥማ መሐመድ አሊ ይባላለሁኝ። የጤና ኤክስቴንሽን ባለሙያ ነኝ።
Okay, thank you. She is Fatuma. She's a health extension worker and working in Afar, Afambo, Warada.
ያው እኔ በጤና ኤክስቴንሽን ሁኜ በምሰራበት ሰዓት ያጋጠመኝን ስቶሪ ለመቅረብ እወዳለሁኝ። ያው ጤና ኤክስቴንሽን ሁኜ በምሰራበት ሰዓት ፋሚሊ የቤተሰብ ክበብ ልክ ከኛ ጋር እንደተጀመረ በቀበሌ ደረጃ የተለያዩ መድረኮችን እያዘጋጀን መጥተናል። በዛን ሰዓት በምንሰራበት ሰዓት በሴቶች ክበብ አማካኝነት አንድ የመጣች በ15 እስከ 19 ዕድሜ የምትገኝ ወጣት አግኝቻት ነበረ። በዛ ሰዓት ምንድነው እሷን ያገኘናት በተደራጁ ሴቶች አማካኝነት ነው። በሴቶች አማካኝነት ምንድነው እሷ ምንም ስለ ቤተሰብ እቅድ ግንዛቤ የላትም፣ ምንም ኢንፎርሜሽንም የላትም። ያጋጠማት ቻሌንጅ ምንድነው የ8ኛ ክፍል ተማሪ ነበረች። 8ኛ ክፍል ተማሪ በነበረች ሰዓት ላልተፈለገ እርግዝና አግብታ ላልተፈለገ እርግዝና ተጋለጠች። ልክ ሚኒስትሪውን 8ኛ ክፍል ነበረች እና ሚኒስትሩን ልትወስድ ስትል ወለደች። ከወለደች በኋላ ትምህርቷን በወሊድ አማካኝነት አቋርጣለች ማለት ነው። በዛን ሰዓት ልክ የቤተሰብ ክበብ እንደተጀመረ እነዛ ሴቶች እሷን ጠቆሙኝ ማለት ነው። አንድ ወጣት አለች በወሊድ አማካኝነት ትምህርቷን አቋርጣለች ብለው በሴቶቹ አማካኝነት እኔ በሚሰራበት ወደ ጤና ኬላው አምጥቷታል። በዛን ሰዓት ሴቷ ብቻ መወሰን ስለምትችል ባሏንም ጭምር በቀበሌ ውስጥ በሚገኝ በጎሳ መሪ አማካኝነት ወደ ጤና ተቋም አብሮ መጥተው ስለ ቤተሰብ እቅድ ዙሪያ ግንዛቤ የመስጨበት ስራ ሰርቻለሁ ማለት ነው። በዛ ሰዓት ሜቶዶችን መቅረብ ነኛ ያለብን በራሳቸው ፍላጎት የፈለጉትን ትምህርቱን ካገኙ በኋላ የፈለጉትን የመምረጥ ነፃነት ሰጠናቸው ማለት ነው። በዛ ሰዓት ምን አደረጉ? የ3 ዓመትን ኢምፕላንትን መረጡ። በዛ ሰዓት ተጠቀመች። ከሄደች በኋላ አሁን ያቺ ተማሪ የዲግሪ እየተማረች ነው ማለት ነው። በዛ በቤተሰብ እቅድ ባገኘችው አገልግሎት አሁን ዲግሪዋን እየጨረሰች ልትመረቅ ነው ያለችው። ምንድነው በዛው ጤና ኬላ ነበር የሚሰራው ለጤና ሕክምና አገልግሎት መታ ነበርና በዛ ሰዓት በጣም አመሰገነችኝ። ያሰብኩትንና የቤተሰብ ደስታ እንደፈጠርኩላትና በዛ በቤተሰብ እቅድ ዙሪያ ያገኘችውን ግንዛቤና የተጠቀመችው ሜቶዱ በጣም ደስታ እንደፈጠረላትና በጣም ስኬታማ እንደሆነችና በህይወቷ በጣም ደስተኛ እንደሆነች ምስጋናዬን አቅርባልኛለች ማለት ነው። ባሏና እሷ በጣም አመስግነውኛል። አመሰግናለሁ።
Okay, I will try to translate what Fatuma said. As she said, I remember she said it was a period when family circle program began in Aurora. An adolescent married girl who was identified for family circle program by the Women Development Area and referred to the health post for family planning counseling service. I met her when I was working as a health extension worker at health post level. Based on the advice of the club leader, her husband also accompanied her during counseling sessions. Thus, I provided the counseling service using the family circle program. Family circle guide. As they confirmed during the counseling sessions, they have no any information before about family planning service. Then, as a result of this, they dropped out of school due to unintended pregnancy. Then, following counseling session, she received long-acting family planning implants. based on their decision. Thanks to, she said, the client, thanks to the family circle, she is pursuing her education, and now she comes to end her BSc degree. As she told me, she said, Fatuma, during her recent medical visit, she is now happy with her family life, and also she expressed her gratitude for the family circle program, which has significantly contributed to her success. Thank you.
Wonderful. I'm gonna second another. Fatima, thank you so much for sharing that story. It's really, I think, exciting to, we talk about the health impact. Of course, this can have a bigger impact on girls. So great to sort of hear an example of where went beyond health and allowed for return to education, which we know is quite challenging. So thank you. Next up, we have Tora Itich, who, as I said, is the County AYSRH Coordinator in Nara County. Are you with us, Tora? Yeah, he's coming on.
Yes,
Hello.
I'm there, Mary. Thank you, Mary.
Welcome, thank you.
I like Mary said, I'm Troy Teacher-san. I work with the Narok County in Kenya. I coordinate adolescent sexual and reproductive health. This is one of the county that PS Kenya, through the Pin Shupafu program, have been supporting us. And just want to pick from where my colleague Purity left. And I want to talk about the methods we use to reach out to the key influencers. And for our county, we had two methods which was really came up strongly. One, we have the male engagement, that is the husbands meeting, and also the partner. And I just want to give a disclaimer that not all the adolescents are married. Some of them are just having partners, and they would really want to also have their reproductive health goals. So in this forum, we used the community structures like Purity said, and in our culture here, we have what we call a court eating ceremony, or a meeting where men go to a secluded place and they sit down. They just slaughter some 2 or 1 court, and then they share their own issues informally under a tree. And we felt like we needed to write on such occasions, because getting men in one sitting to discuss issues, especially on sexual and reproductive health, is not easy. Another reason why we chose to have this male engagement or forum to discuss sexual and reproductive health is that we are living in a predominantly patriarchal society, where men wield a lot of societal power, and also they are the custodians of societal norms, and therefore we felt like these are the people that we reach, so that they are able to empower and also support the girls, for them to access contraception and other sexual and reproductive health services. So we formed our county, and we formed groups of those men, so that at a given time we engage them. And during the engagement, we just have a moderator from the health sector, so that they put things into perspective and give them facts on sexual and reproductive health, especially family planning. And therefore, this healthcare worker must be a man, so that it goes hand in hand with the societal agreement that in this forum of men, a man is the one who is moderating, because they don't allow a woman to spearhead, because it's actually a men meeting. So that is one way of reaching out to these men. Number two, influencer is the women. That is the women groups. We know that these girls would confine, and they will feel free to discuss issues of sexual and reproductive health to their mother-in-laws, to their mothers, or even the traditional path attendants. So we felt like also this is an avenue where we needed to empower these key influencers in terms of the women, so that they are able to refer, they are able to share in correct information to these girls. So once we have completed the meeting, or we have finished the meeting in those groups, we provide for them, like my fellow presenter said, some cards, so that as they refer the girls, they give them those cards, so that when they visit the facilities, the dispensaries or the health centers, the healthcare provider will be able to understand that this one was referred, and also it helps us to track on how the community dialogues and the meetings work. But that does not mean that they must come with those cards. Some can be referred verbally, some can be accompanied. So we didn't also close out those ones who don't have a card. And through those and among other interventions, of course, we are able to reduce our teenage pregnancy generally from 28% to 28%, according to the Kenya Demographic Health Survey of 2022. And as we are speaking today, by the end of 2024, our service delivery teenage pregnancy data reports at around 24.5%. And I also want to say that through the engagement of husbands, because we know that these are the ones that the men are the ones who are providing permission for these girls, for these women to attend clinics. We felt like it is very, very important, because according to our data, most of our girls are semi-literate. Most of them are primary school dropouts, and therefore they may not have the financial power and even the capability to decide on themselves. So we had to bring on board the key influencers, those are the husbands and women. And that has also improved our family planning uptake by this age cohort between 10 to 19 years, from around 6,500 in the year 2022 to around 13,000. That is a double digit. So we feel like this is the way to go, bringing the men on board and let them understand that for us to achieve the reproductive health outcomes for these young girls, we needed to also improve the accessibility to contraception. Thank you so much, Mary.
Wonderful. Thank you for that overview. And it's incredible you have the stats at your fingertips to speak about sort of how all this work leads to changes in contraceptive uptake. Because we're short on time, I'm going to turn immediately to Ibrahim now. Ibrahim is a male IPC agent from Nigeria. And Ibrahim, I'm hoping you can talk to us a little bit about, you're out there talking to husbands. What sorts of resistance do they put up to family planning? What sorts of things are they saying to you? And how do you overcome those concerns or those barriers and that resistance?
Okay, thank you very much. Implementing a family planning project in northern Nigeria is not an easy issue, because it's a place whereby they are rooted with Islamic beliefs. So they see it as a taboo to their religions, and they see it at times as an alien. So some of the things we do, or some of the approaches we use in overcoming some of these challenges, we use a cultural sensitive approach, in the sense, when the project came is A360, so we even try to localize the name. That's why we are using Matasa Matan Arewa, which the translation is that adolescent that are married in northern Nigeria. So even using that context only change some of their norms. So when we are engaging the males, another things that we are doing is that we try to, first of all, tell them about the benefits, the economic benefit and health benefit of family planning before later introducing the family planning to them. And we are always very careful not even to use the word family planning. We rather use the word child spacing, because they have this belief that this family planning, what they know is that they want to stop people from giving birth, so they want to reduce their population. And they have this belief from one of the hadith of the Holy Prophet Muhammad sallallahu alaihi wasallam, that he says in the day of resurrection, he will be very proud of his population. Why these people are trying to reduce their population. So we told them that, no, this is not about reducing your population, rather than just to have a space. If your wife, as adolescent wife, is not that strong, give birth, she needs to rest at least for 24 months, that's 2 years, before giving birth again. That will enhance the family economic capability. That will go a long way in sustaining that family. Another thing we do is that there is a lot of misconception coming from different places. You know, they have all these place that they used to sit and rest. They will be telling themselves that if your wife took family planning, she's not going to give birth again. She will be sick. All sort of things will happen to her. So we try to address those misconceptions through telling them the benefits of family planning, and also some of the potential side effects in case it may occur. And we also tell them that, okay, when the adolescent wife gets to the clinic, she will be counseled about the different method of all this family planning before she will choose the one that will suit her system, so that whenever any complication comes, or she notice any side effect, that will not be an issue to them, because they are already aware of it. Another issue is that at the beginning, there is this issue of trust. So we try to build that trust in making partnership with the local organizations in all those localities. Not only that, we try to see concept of the religious leaders wherever we enter, and even the community leaders through there is a structure called WDC, that's World Development Committee. So they are very influential in telling the husband that this action, or some of these things that comes, they will enhance your life. Is not, in a place whereby they are rooted with culture. They see the words from their leaders and traditional rulers as very important. Even no matter how truth you bring something to them, if you didn't follow that channel, they will see as you are just wasting your time. So another thing that we did again is to try to those husbands, they have this issue of dominance to their wives. In a core northern house, you find out that the wife don't have a say. The husband is the sole decision maker. So the husbands are even hesitant to even discuss issue around family planning with her, not to talk of putting her in decision making of the family. So we try to engage those husbands to make sure to tell them that, no, it is not done this way. This decision making of your family, you have to include your wife in it. And fortunately, or as it is now, we have made a very significant achievement over the year, whereby there is so much evolving behavior and even shift in social norm as it is now in northern Nigeria. You find out that there is increased acceptance of family planning. There is also another achievement that we made through our
I'm so
and
sorry to cut you off. We are at time. So just finish up this last thought, and then I'm going to wrap this up, okay?
Okay, thank you.
You done?
Yes.
Okay, thank you. I'm so sorry to cut you off because you had so many interesting things to say.
Yes.
But I want to be respectful of people's time, and we are at the hour. So just want to say thank you to our presenters and to our panelists. They worked quite hard to prepare for today, so we're extremely grateful that they came and shared their knowledge. And thanks to everybody who joined and listened. We will be sending out a recording of this, and we will try to answer any questions that we didn't get to. I think, Ibrahim, you wrapped us up really nicely, because there were a bunch of questions about, how do we ensure that girls still have decision-making power, and we are putting them at the center and making sure that we are promoting and supporting their choice. And that is something that A360 thinks a lot about, that we sort of underemphasized on this presentation, but would be happy to discuss that further in another forum. So again, thank you so much, everybody. Enjoy your mornings, evenings, and afternoons, and we will send out the recording. Thank you so much.